Hi, and welcome to MedInsights Unleashed podcast. I'm John Collins, and I hope you enjoyed this new episode, and thank you for listening. Well, hi, MedInsights Unleashed listeners, and I just want to thank you all for your support. We've got a special guest today with us, Patrick Coyle. Patrick and I have known each other from the business side for a long period of time now. We've worked together. Patrick's specialty is finance, but he's also heavily into patient advocacy and reimbursement. So, Patrick, would you like to introduce yourself to the audience?
Yeah, thank you, John, for having me and looking forward to the opportunity to speak to your audience. I joined the pharma industry after spending a lot of time in IT and financial operations roles because I wanted to get closer to the patient. My mom was a nurse and she had a variety of different roles helping the patient. And I always wanted to figure out a way that I could take finance and do that to support the journey. And I found that in pharma. And after spending time at some pretty big organizations, also some small ones, I came to this side of the house to find ways to help those companies be better for patients and for patients to get access to the therapies they need.
So on LinkedIn, Patrick, you talk a lot about finance and gross to net, but you also talk about the patient journey from the prescription side. And when a patient actually gets the script, this is a topic that we've never really discussed before on MedInsights Unleashed. Is what's the process for a patient? We know that patients have a heavy time with copays, especially today with the financial situation. So can you give us a broad insight from your side as to the role of the patient getting that drug and then the copay associated with it from a reimbursement side?
Yeah, and I think in pharma, we forget what it looks like to be a patient that doesn't know any better about the economics or how to navigate a brand journey from a prescription. And so what we realize now, going backwards and just looking through the eyes of a patient, which we always should do, they don't know what to expect. There's a diagnosis, there's something going on that is probably news that was not well received or as expected. And then all of a sudden a prescription is written. In the old days, we used to get a piece of paper. For the most part now, we don't anymore. But that e-prescription gets sent through a system that's going to connect to the pharmacy of choice more often than not. That's why they ask you. And from there, the system takes over. It comes back to what your insurer is willing to cover or not cover for your prescription. Are you a government patient? Are you a commercial patient? There's economics at play that will help you get your prescription filled, or they're going to hurt the chances of that prescription getting filled. And so I think it's a great opportunity now to talk about the things that help and hurt that journey from a patient perspective.
The branded prescription, and then there's the generic prescription. So what's the difference between a branded prescription? You and I both spent long times in the pharmaceutical industry. When we've got a branded script, it goes through a significant process, an evaluation process of rigor. We haven't really discussed that before from a generic side. And then there's also the prior authorization associated with some specialty scripts that many of our patients, especially those in the cancer field, those are very expensive drugs. So we've got a different field for those patients that are receiving cancer therapy versus those patients and for all other complaints.
I think backing up to the pharmaceutical side, it all starts with the price, right? And the price of the product at list or WAC price, and then it starts to move through the channel.
Can you explain what WAC is, Patrick?
Yeah, it's a manufacturer's list price, right? For all intents and purposes. But wholesale acquisition cost, it's the price that you're going to sell out into the pharmacy network from more likely your third party logistics company, from the warehouse that has these finished goods with the right label on them for commercial use. And then it's going to start moving through the channel, whether it's through a specialty wholesaler, distributor, retail. It's going to be different depending on type of product. And it's going to ultimately wind up in the pharmacy of an institution, or it's going to wind up in another pharmacy. And I think there's different types of pharmacies is the first thing to understand, right? Some are retail, They are big national channels, and that consolidation keeps occurring. And some are independent, and some are vertically integrated with your insurance companies, pharmaceutical benefit manager who's managing the cost of the claims, or the group purchasing organization that's managing the rebates, and all tying this into the formulary positioning for where that product is going to lie, right? That's the pharmaceutical side. The patient doesn't know anything about that. The patient just knows they have something wrong. They want to get better. They get prescribed a therapy, and then they go to the pharmacy. And at that point, the pharmacy, they don't know the system. Let's pick on commercial insurance. So I have a job that, thankfully my employer covers my insurance. I pay a premium. It's taken out of my paycheck, but I don't know what products are on the formulary. So I don't know which ones that the employer plan feels are appropriate to be covered or not covered, and at what cost being passed down to the patient. So they're all of a sudden they're managing that relationship in between the pharmaceutical company and the patient. And then that's where the things start to get more and more challenging, right? Because the patient doesn't know what that list price is that we talked about. The patient doesn't know from an affordability perspective, how much is it going to cost me? How much is my plan going to cover? Is my plan going to cover it? And then that's when the economics of the system start to take over and really complicate things, because a lot of it's going to have to do with how different the medicine is from a similar product or therapy. Is there a generic equivalent? Is a generic even really equivalent, to your point? What is the cost of that generic, right? So there's a whole cost for the reimbursement of the pharmacy. And then you start to get into the economics of the pharmacy and what are they going to make on that prescription as a transaction. All these things are completely blinded to the patient, but all I know is, I need to go get my therapy. And then you show up at the window through the drive-through or at the counter, and that's when the process starts taking over.
One of the areas that we see a lot, especially in the field of cancer, as well as in some antibiotics too, by the way, is that patients need a prior authorization before they even get the pharmaceutical agent. So what's the processes from a prior authorization and the appeals associated with prior authorization?
Yeah, so I kind of explained a bit more on the retail side, but I think when you talk about high cost or products, and especially in the oncology space, but that require a lot more special handling, what they may have a black box warning where certain safety has to be regulated, adverse event monitoring, things like that. We're getting into the specialty pharmacy distribution channel, right? So the patient's more than likely not just going to pick that up at the store. They're going to call. There's limited distribution having it. In this case, it's going to be a very different journey than a prior authorization, but prior authorizations more and more for line of therapy in oncology are there because we're seeing a real tremendous influx of generic oncology medicines. And with that, it's going to be that there's significant difference in the cost of the equivalent. So the payers put together these prior authorizations or utilization management that they call it to help start to refine the question is, what is this the appropriate patient, right? Have they tried other medicines that they're supposed to try first, whether it's in the clinical design or whether it's something that they feel from real world evidence that's important for their outcome. But they're starting to control the economics of the prescription, right? How much they're willing to pay, how much it's going to cost them, how much care they're going to have to give, how much care does the patient need. These are prior authorizations that are steps to put in place to, let's say, to make sure the appropriate patient gets the appropriate product. However, it's also a big economic lever for these payers to delay therapy, to start to control how much of the therapy they're going to give you until they figure out if it's going to be appropriate for you. Maybe I'm not going to give the patient a 30-day supply, even though the patient's prescribed a 30-day supply, because I want to see if there's going to be some bad adverse reaction to the therapy for the first 2 weeks of therapy, right? So that limit is a type of utilization management, right? Prior authorizations, back to that question, has a patient tried a generic medicine? So sometimes they say, well, you have to try this generic before you can get onto a branded, or your second line therapy, you had to have failed the first line therapy that's approved as a standard of care. So it gets pretty complicated. The patient doesn't know any of this stuff. The patient just knows I need a therapy.
So one of the things that we're wanting to give the patient information through this episode with you, how best for a patient to find out about that? Is that a discussion directly with the pharmacist and find out the information?
Well, since there's so many different types of let's say cost and specialty medicines, I think the conversation is best starting at the office, the provider's office, right? And sometimes it's the office administrative support, sometimes it's the doctor, but most of the times the admin are the ones who are used to getting these prescriptions filled. So you could certainly ask, instead of just walking out not asking any questions, you could say things like, "Do you think my insurance is going to cover this medicine? What are you hearing about how difficult it is for a patient to obtain the medicine? If I need to contact, if the pharmacy needs to contact the office, can we do that? Is there information that I can provide based on other medicines I've already taken that you may not have in your chart? Maybe it's in your doctor. How can I best prepare the office and understand what they've seen for that patient journey on that type of or similar one?" And that's also where things go wrong, because that office staff may say, "This is the experience we have." But that's with a certain type of patient. That could be a Medicare patient, that may not be a Medicaid patient, it may not be a commercial patient. But to the provider, the provider's office, it all kind of looks the same. It's a patient journey. Is it easy to get on therapy? And part of that is, can the patient afford it? And if not, it's likely not easy to get on therapy. But if there's operational snags in the process, it's also going to be hard for them to get on therapy. So it starts at the provider's office. And then when you get home, or you're contacted, or you get a pop-up in a text message, or however the way they're going to contact you, go to the retail pharmacy, that's when you need to start taking control of your part of the prescription journey, what you can do, right? And sometimes, and I think the hardest part is forgetting what I know already, or and then looking at this the way that somebody who hasn't worked in the system for so long may. And when you go there, pay very close attention to the medicine that you're being prescribed, right? And so there's the generic molecule name, and then there's also there's the branded name. And it starts with, okay, you were told you're going to get this branded name, but you didn't get it, right? So now you have the molecule name, but you don't know if it's generic. You don't know is the generic even the same? Where was the generic made, right? Is there something special with that company that made the branded one that's the one you're supposed to get? So do you call back the office and find out, do I want to take a generic equivalent? Or sometimes they just switch you to a product that may be over the counter, because your insurance isn't covering that, because there's other options available. Well, the doctor wanted you to have a different therapy because it's whether it's experience, or whether it's in the clinical design, or whether it's adverse events. Things start to get shaped by the insurance company and the pharmacy that may not be what the intent is. So you have to ask questions. You have to make sure you're getting what you're supposed to. And if you're not, then it goes to, okay, why not? And a lot of times the pharmacist is trying to operate also within a vacuum of not necessarily knowing what the whole pharmacy is going on. And that's the difference between whether you're going to a retail pharmacy with a lot of turnover versus a specialty pharmacy, independent pharmacy, where maybe there's a little bit more personalized understanding of the prescription, right? And they can start to tell you, well, this is a high cost. This is going to be a high cost to you. It's not covered, so it's going to cost you $500 out of pocket, right? And so sometimes they just assume you don't want to pay $500, or the other. Sometimes the patient just pays $500 because it's really important to get it. But in that process, someone's making assumptions, or you're not asking the appropriate questions, because a lot of times the manufacturers provide support. So let's say you're a commercial patient, they have copay program, which is used to, brand and manufacturer providing funding to support to support your therapy, the cost of the therapy, and bring down that out of pocket, which could be high based on the insurer's coverage. So these things you have to also ask them, is there a copay program available? If there's a denial of coverage, or something that says, we're not going to be able to cover this. We're not going to be able to fill it. You then have to also ask, there's so many different paths here. Is it because you don't have it in stock? Oh yeah, we don't have it in stock. Well, why not? Well, I haven't been able to get it for months. It's a backlog, a national shortage. You get that a lot. That's not always the case. Sometimes it is, but sometimes it's just that's not something in the pharmacy's interest to stock. So they want something else at the point of sale. But sometimes it is, right? And it's hard. It's a backlog. It's hard to, manufacturing shortage. So you have to really be very inquisitive of what you're getting is what you receive and what you should be paying for that, or willing and able to pay. And don't be afraid to step back and ask the provider, "Hey, I'm having a problem at the pharmacy." That denial of coverage also sometimes because they just don't think that it's medically necessary. Your insurance plan or the PBM governing the pharmaceutical benefit manager does not, has these steps in place that says that you're not qualified, right? And so
So many of the specialty pharmacies do have reimbursement specialists. Is there a special way on the patient side to enhance the communication?
yeah, and I think there is the distinction, which is so tough because the specialty pharmaceutical that's limited distribution, whether it's the retail pharmacies or bigger independent pharmacies or mail order, uh, they more likely are going to have somebody that's whether it's for the pharmacy that's going to reach out and help the patient initiate therapy, or whether it's the manufacturer may also have support that's offered through a third party administrator. But you have to find that, right? So a lot of times the retail products don't have that. But it's the number one thing you should do is, as a patient, find out, okay, do a web search. What does the manufacturer have? Ask, can someone contact me about support? I'm having trouble obtaining the therapy. So greater than 70% of prescriptions that go more than 3 days with a prior authorization required don't get filled, right? And so,
Yes.
and it's horrifying to know. But meanwhile, a lot of these prior authorizations take that. You have to go back to the office if there's not a reimbursement specialist, like you said, or somebody working with the provider's office, someone working with the pharmacy to try and help break down the coverage. A lot of these forms that have to go back and forth, there's so many technological enhancements today that exist, but they're just not available to everybody or every brand or every pharmacy. So a lot of times it's a fax back to the office. Faxes get lost. The transmission isn't clear. We need you to fill out these things about the patient to figure out if they're appropriate. Okay. So that's something you can ask the provider too before you leave, like we talked about, or if you're having a problem getting the product, is, do you have this symptom? Do you have that symptom? Again, it's probably baked into the prescribing decision. However, based on the clinical guidelines, however, it doesn't necessarily translate into the paperwork, right? So it's also a good thing to ask the office before you leave. Is there anything that we're going to have to do in case there's a prior authorization or a medical necessity or something with the denial of coverage that's going to have to help me get this therapy?
One of the things that's advertised is the pharmaceutical companies can say that we're here to help you, to assist you with getting this particular agent, this pharmaceutical product. But there's no information given by the pharmaceutical company on that commercial for the patient to actually approach the pharmaceutical company for the assistance. Now, you're working very, very closely and have been over the last multiple number of years within pharma to broaden this aspect of the pharmaceutical business and to enhance the pharmaceutical company's approach to the patient and for assistance. How best was it from a patient perspective to approach that company for medical assistance and medical need with the agent that they've been prescribed?
Especially when it comes to income levels and federal poverty limit, every brand that's going to offer some kind of patient assistance program has different thresholds for what they're willing to, within the structure, provide the therapy at no cost, right, to a patient in what they call the PAP program. But those are sometimes buried on the website.
Can you just say what the PEP program is
Yeah.
and how it works?
Yeah, so I think there's two main distinctions, and a lot of things get blurred out there. But there's a PAP program, which is patient assistance program, and there's a patient support program, like a PSP. So the PAP programs are free goods designated for an appropriate patient with commercial coverage, but that's not making enough from an income level that these pharma companies have a certain amount of drugs set aside funded to be able to provide to that patient to get the therapy. I think it's one of the most maybe least known right options out there, right? And so one thing is just for patients to know that there's a place to go in case the answer is no, or I don't make enough to afford this product. So that's one thing. And the patient support programs are more like we were talking about the copay. So I have commercial insurance, but it's going to cost me $1,000 after the insurance pays their part. I can't afford $1,000. A lot of times you'll see on TV, pay as little as $35. Pay no more than $0. Pay $0 for. These are important. You have to pay attention to those advertisements, or look on the web, because what that means is they're going to take you from $1,000 if you're a commercially insured patient and you have the appropriate coverage down to 0 or $35. That is the pristine kind of approach from the pharmacy to try and help make the drug more affordable and accessible by broader patient base. But what really happens is then there's all these other actors out there that say, well, we're not going to have your portion of the payment. So let's say it's paying no more than $100, and I'm paying $100 for that. It doesn't go to my deductible, right? So this is where kind of the games start to happen behind the scenes with the payers to say, well, the pharma company is willing to support this, so we're going to have them. It's not going to count towards your deductible, right? So if you're on this therapy all year, it's not going to help support other programs, and we're going to make that. There's also ones where they say, well, we're going to make sure we can take advantage of every dollar of that program versus just, so if they would have provided the coverage, but at a lower copay, they're going to charge a higher copay and they're going to charge the manufacturer program. These things are bad for pharma companies because it erodes the profits. And on the patient assistance programs, now they even have these things called alternative funding programs, where there's third parties that step in and say, you're a commercial covered patient. However, the manufacturer's got some pretty broad guidelines for their PAP program. So we're going to switch them over there. You're going to get free goods. You're going to get on therapy. That's great news for the patient. But the manufacturer actually did everything that they needed to do to have that prescription covered. And a lot of times, in order to do that, they have to pay 20, 30, 40, 50, 60% of that WAC price we talked about earlier has to go as a rebate to that group purchasing organization that's managing the PBM or the PBM directly. And so what happens is, they're diverting the funds. When a lot of times when we look at these pharma prices, we don't realize that is not the net price. That's the list price. There's all these things in the middle taking out. But it's really important for the patient to know where the economics are and what they can do. And the patient at that point can also ask their insurance company, when the prescription is filled, is this going to count toward my deductible, right? What I'm paying now, what the manufacturer is paying now, how much of this are you going to cover, right? Are you going to continuously cover it? You have to, if the insurance company pushes back, you have to ask questions. You have to write letters. You have to do appeals. That's why they have all those in the explanation of benefits they send you, for these denial, because they think most people aren't going to take the time or understand what they have to do, but it's okay to ask questions.
Yeah, there's a lot of discussion just recently on the news across the United States about GLP-1s and the cost associated with it. While GLP-1s got major benefits for the patients across from cancer patients right through to obesity, the costs associated with that in the short term is really significantly hitting the funds as well as the reimbursement associated with it. A lot of the funds are actually tightening the approval of GLP-1s and making patients go through the loops. Have you been on other therapies before you get to the GLP-1 now? How do you see that in the future? The same sort of process for any prescription drug?
Mm. Well, there's a lot of really good questions in there. One of them is the geopolitical landscape and pressures from the IRA and maximum fair price negotiations. And what's happened is it's put a lot of downward pressure on the price of medicines that manufacturers. So if you're one of the GLP ones and somebody else in the class is now getting negotiated for that MFP, everybody comes down.
MFP?
Yeah, the maximum fair price, right? For the government negotiation with Medicare. So what's happening is overnight, that list price for that product has come way, way, way down. Some of them 60, 70, 80%. Really big products. The GLP-1s are a big one of those classes. And then if you're another GLP-1 in there that had a high price, but wasn't, targeted but for this MFP because of past pricing, increases and over and above inflation, things like that, they get sucked into it too. So all of a sudden now the GLP-1s without a lot of differentiation have to go lower and lower in price, right? So they just drop the floor and they say, we're going to go direct to patient and make this available at Walmart or Costco for $125. Good for patients. But what I worry about is what does that do for these companies with all the innovation, right? And I talk a lot about patients and profitability. We're kind of walking between both worlds here. It's going to meet in the middle, right? Because there are a lot of bad actors that have taken, exorbitant prices that, weren't funding innovation. But then there's also plenty of them that, it costs upwards of $2 billion to bring a new product to market. So when you start gouging the pricing for these products and come down to this direct to patient cash price, what happens to innovation? How do we keep funding that? For a patient that wants a GLP-1, it's great for $125. But to another one of your points there, when you have these drugs that certainly start to look like miracle drugs that can do so many different things and are being studied in Alzheimer's and weight loss and all these other indications, how can we sit here and say that those shouldn't be available to everybody when it has such a huge potential impact on society? So we're at this great inflection point, and companies are getting in trouble, some of them with this direct to patient, because how do they do that, right? How do they do that? Just offer a cash price at arm's length. Pharmacies, what's their role? It's evolving all the time in here. I think for the patients, you have to pay attention. You have to pay attention because it used to be a pretty clear roadmap, and it's not anymore, right? The last few years, because of the rise of the GLP-1s, everything is different, right? You see commercials. Well, I can just call a number from this company or that company and all of a sudden get this product and speak to a doctor for a few minutes on the phone. How is that, how does that work? So it does, but there's going to be more and more change. There's also more products available on Trump RX, right? That are signing up saying, okay, we're going to go make this product more affordable. A lot of it's driven from that IRA, the MFP that I talked about, but not all of it. So it's a very interesting time to be in pharma. And then we didn't even talk about the economics of the pharmacy, right? And maybe going back and swinging to the other side for a moment, the pharmacies are under pressure because the reimbursement from the payers are less and less for the product that they're dispensing, right? And then, so without a lot of that technology, they're being forced to do more and more with their staff. They're understaffed. There's not enough time. You see mandatory lunches now because they're not even eating. So the poor pharmacists, especially the retail ones, are really, really getting overworked. And you've seen that since COVID. And so the pharmacy is not making a lot of money on a lot of those transactions.
So why aren't they? What's happening in that pharmacy? What's causing that erosion of both personnel and profit?
Well, because the margins are getting squeezed. And so they're either, a lot of the products that you go to get the prescription, they're not reimbursed to the pharmacy. They're either not reimbursed or under reimbursed, right? And if they're under reimbursed, what the acquisition cost of the drug ingredients and what they're dispensing, it's a small margin. So if it's a small margin, it may not even be covering the cost of the pharmacist that's working overtime and getting paid all that overtime. Or, and there's a lot of consolidation. So right, obviously, the economics should be very different for a large big box pharmacy than an independent. They have a lot of their own corporate interests, the bigger ones. But, that's the under reimbursement is a real challenge.
Well, one of the things that's happening, and it really came up in COVID, is compound. It's opened a doorway to really get these drugs to the patients. I know that you're at the cutting edge of that. What's happening with compounding and e-scripts to the patient? There's many companies involved with that now. There's new technology coming into the system. Maybe you'd like to talk about that.
Yeah. I think you hit the nail on the head when it was COVID and necessity that we had to step in and have a compounding pharmacy take the same ingredients and put them together in a way that is supposed to look as close to that product that they'd be getting from the pharmacy that's already coming in a finished good in a pill form already, right? For exemplary purposes. What happens is the compounding pharmacy is putting them together there for you and creating the finished good for the patient. And that was because we didn't have enough access to the hospitals or to the pharmacies. We couldn't get enough product. Like you said, I think COVID really started that. But then I think with the GLP-1s, you started seeing, especially when they were injectables, these compounding pharmacies jumping on it and saying there's a lot of money in here from a profit perspective. It takes away from the innovator drug and all the things that we've talked about on the show that have to go in there to get that product to the patient. So it short circuits the whole process. Then the immediate question that came up was we saw a lot of safety problems with that. I think a lot of those have sorted their way out. But how do the pharmacy and the manufacturer goes through quite a bit of rigor to make sure that that product has gone through the testing and good manufacturing processes and making sure that it gets to you in a safe form for you to take. But when you short circuit that whole process, now it's up to that individual compounding pharmacy to put it together properly, right? And you start to also get into the whole generic conversation, right? Same ingredients, you have to prove it gets in your bloodstream just as fast, the bioequivalence as an innovator. But what if the way they put those ingredients together is a little bit different? Then it's not safe anymore, right? So you brought up a huge Pandora's box to open, that when you go get that pill, is that pill really even what it's supposed to be, right? Did the pharmacy compound it properly? Were you supposed to get 5 milligrams? And just make sure you don't see a 10 milligram on the pill. Because guess what? Sometimes people make mistakes at the pharmacy. I've seen that. So look at the pill when you're taking it. Make sure it's the thing it's supposed to be. If you don't know what it is, do a Google image search, right? Make sure it matches the label. Is the label consistent with how the product's supposed to be used, right? So, and if it's not, maybe the doctor prescribed it differently. But there's a lot of work when the Food and Drug Administration approves a product. It's with a very specific use, right? For the clinical trials, the way they've studied for the patient. And that gets into that package insert and the label, right? But sometimes things are prescribed not the way as intended by the trial or design of the system. So as a patient, you have to be your own advocate to say, okay, is this okay? And by the way, am I taking 2 or 3 other medicines? And that trial was not studied with 2 or 3 other medicines. So when you get that pill, you better think back to your doctor. Did your doctor ask you what other medicines you were taking? Did you fill out the form properly and really tell them, or did you forget and not tell them, right? And so now you start to get into the continuity of your own care as a patient. You better make sure that you know where you've been on your journey, right? Because your doctor may not, the pharmacy may not, right? There's technologies today that are bringing that together, like MyChart, very, very challenging for a lot of people to use, but it's trying to integrate all these medical records, the electronic health records and medical records. But it's really important because otherwise they don't know what you're taking.
We see it from an EMS side where you've got polypharmacy and you've got multiple drugs being used by patients. And it's, as you just said, and I just want to reinforce this, is that it's very, very important that you be upfront and honest with your doctor and your pharmacist, what you are taking. That includes all your vitamins, etc., because you can get interactions across the board. And it's very, very important, as Patrick's just stated, that you are totally transparent about what you're taking to ensure that there's no interactions.
Yeah. And I think sometimes don't assume that they've done as much diligence as you have, right? I mean, it's just, it doesn't mean they don't want to, just they may not have perfect information or, the time to go through the records or like we said, the trial may not have studied this. And so there's been times where I've had family and I asked them what they're taking and I went and researched it online and it says, don't take this with, this and these conditions or these contraindications or a different therapy. So it's really about empowering the patient with knowledge of what's going on, not just we started off talking a lot about the economics and how to get it filled, but how do I make sure that what I'm taking is safe and I'm taking it in the way it's been designed to be taken.
What does the future assistance look like from a patient perspective and a manufacturing perspective?
Great question. So the technology, especially in the last year or two, has really evolved. But that doesn't mean that there's 700 plus commercial pharmaceutical companies. It doesn't mean they're all doing the same things. They're not. They're doing things totally different. Some of them are just doing things within their own brands totally different. So there's a tremendous opportunity to leverage these technologies. And I've always been a huge advocate for the patients. And so I think empowering the patients to sign up for programs, to sign up for information, to sign up for support is really important because there's a big firewall put up in the system. But at the end of the day, the medicines that they make are the medicines you take, right? So you have to work around that in a compliant way to say, listen, I need to know about the product. So the pharma company needs to tell me, the provider needs to tell me, I need to know what the economics are. And there's technologies to do that bring consent, or a patient can consent onto a therapy and it pulls it straight through to your medical records, your provider records, your pharmacy, the manufacturer, clinical trial, the real world evidence that may be out there, or even social media, right? And what other people are saying about it. It's really hard because we leave, and especially if you get a bad diagnosis that you're not really looking for, and your mind's reeling, right? And there is help, but the system was not designed in a way to bring it all together. So, what I encourage the pharma companies to work with them today is to bring all that information together. Let the patient decide if they want to engage, right, at that arm's length and receive all that information and be plugged into the system. And it's really important they are.
Yes, you bring up a really good point because you and I both know that over the last 18 years, we've worked with 3 major companies that have gone to extraordinary lengths to enhance patient adherence and compliance by supporting specialty pharmacies and nurses in those pharmacies and reimbursement specialists so that the patients do get all the information and their adherence and compliance is definitely improved for those patients that actually enroll in those programs. And you bring up such a good point. What astounded me is that not every patient wants the calls every time. I know it can be a bit of a bugbear. I'm getting that from my healthcare provider now. You get called, we noticed that you went to a pharmacy and picked up your drug. Are you okay? Have you got? But I think that service is excellent because it's following you, it's following your script, and it's also following your outcomes associated with that script. And that's a definite yes for me and a big tick for patients to seek out that support that's supplied by those pharma companies. It's amazing for everybody involved, not only for the patient, but for their caregiver as well.
Yeah. I think they spent billions of dollars, right, to do that, to try and help patients, but they can't connect to them,
Yeah.
right, directly. And that's the way that everything's been designed. So it sounds counterintuitive for them to do so much and then not make it to the people that they need to. And at the same time, I think there's been a great, distrust of the system, but the technology's evolved so much today that if you're going to opt in for TV ads, you might as well be opting in for your prescription, right? And so it's amazing the
It's a
things
good point. It's a good point.
yeah,
Yeah.
we opt in everything else. And, so I can tell you, there's so many more data layers of security layers on the data for when you opt into these things. But it's important because, the technology knows when you've been taking the medicine regularly, right? Or when you've been skipping a dose. And those things lead to bad outcomes, right? The doctor gives it to you with a set of assumptions that you're going to take it all the time. But how does that doctor have any idea what you're doing? What if you're skipping every day? What if you start doubling up? So there's huge opportunity to and these technologies, very few of them, but some really good ones are doing that. So your doctor could step in, because I was at the doctor the other day and the doctor said, patients taking the medicine the way that they intend to, not the way I wanted it to. Right. And so by the time they see him, maybe 2, 3 months, 4 months, and then all of a sudden they find out it wasn't working the same way. Well, you had to have not been taking it the same way, or you were, and then I needed to know if something else happened. So, the pharmacy is not always closing the loop with the provider's office too. But when you have,
Mm.
technology and you're willing and able to get into that matrix, then everybody's helping you better.
Yeah, that was one of the big things that when I was working with, won't mention the company's names, but when we were working through the specialty pharmacies, the patients would get the call from the nurse, especially in those patients that were receiving oncology agents. And if the patient did talk about having an adverse event, then the specialty pharmacy nurse or pharmacist that was answering that call would actually reach out directly to the doctor and to ensure that the loop was closed. So again, it really supports what you're trying to advocate for, Patrick. I just, it astounds me that it's not being advocated enough by both the pharma industry or pharmacies. So I just wish that, those people that are listening to this particular episode really start advocating to close that loop.
Yeah, and it used to be that the adoption, especially for Medicare patients, the technology adoption, the cellular phones wasn't there. It's just not true anymore. Um, Everybody's got a cell phone. The numbers are ridiculously high. So if the technology is working and it comes to you and you can get into that, it's really important you answer the phone, right? So that's what you're saying, right? Answer the phone, answer the text, because if you don't, nobody knows what's going on. And all the improvements and the pharmacies are all different, but let's just say they're all giving the same level of service, which is not always the case, right? And they're reaching out. You have to answer it. Otherwise
Yeah.
you're in the black box.
Yeah, they have to reach out for sure, but they also have to answer the phone. I know from a patient perspective, sometimes you reach out several times and sometimes there's no answer. And that's something that you really need to talk to your pharmacist about, or the group of pharmacists, or if you're in a major retailing outfit, they need that feedback, especially from the patient, to ensure that the patient services are being provided. Patrick, we're nearly coming to the end of our talk. If you really wanted to sum up this conversation into 3 to 4 major bullet points, how would you finish off the conversation? What are the critical factors for the patients and healthcare providers that are listening to this should leave with?
I think it's an ecosystem and we all have to work together, right? The patient, the provider, the pharmaceutical company, the pharmacy, that all has to come together. And the patient has to ask questions. If you don't ask questions of the provider, if you don't ask questions of the manufacturer, if you don't ask questions at the pharmacy, they're going to make assumptions, right? And it's, I think so many times we don't do what we have to do. So the system is actively, we talked about it, working against, trying to make sure that it's worth paying for you, right? Or who's going to pay for it. But we can find a way to get there together, and you're seeing that. I think the walls are going to come down more and more than ever, but the technology is coming like a freight train. So we all have to get on board with it and do it. And like I said, there's a lot of different therapies, a lot of different companies. The one thing we can do is take control of our own journey and do research, right? Research is easier than ever. Doesn't mean we should all be self-diagnosing on the internet, but the technology will do a lot for you if you let it today. The AI, just use it with caution.
I was just thinking about the EMR. Like, we live in a world like every healthcare provider, even those first responders now, all have EMRs. We're working on an EMR process. How is that in the future going to assist us? We know that countries like Norway and Sweden have centralized EMR systems. I, I suppose it's easier to do that in Norway and Sweden, but what's the future in the United States about collectively bringing that EMR together? Not only transparency within New Jersey, for instance, because every state's going to be slightly different from a reimbursement system. So that's very, very important for every patient that listens to this. It does change from state to state. How does that EMR system work for the future to centralize it? What's happening from your end to bring that together?
Well, I think the government is working harder than ever now with Operation Crush and some other things to try and keep combating the bad actors of the fraud, waste, and abuse, and the people that are actively obfuscating and looking to give you less information because it's not beneficial for their economic motives, right? So I think the more and more they put pressure on information sharing, it's like you said, every state's different, but I think we have to work toward a national standard of, okay, we're not going to operate within the same payer structures or that a lot of the rest of the world does. We know that, okay, but instead of always trying to fight for that, maybe we fight for standards, like we did with HIPAA, and privacy protection years ago. Maybe there's standards for how patient information should be available for every prescription, for every doctor visit, for every plan reimbursement, all that information, right? Because it's really in the best interest of everybody. And I think that for at least the government portion, we're getting there a lot faster. But I think the commercial, we have to get there too. So there's got to be some national standards put in place.
Well, Patrick, I want to thank you for your time today. It's been very, very insightful, and hopefully for the patients and healthcare providers that are listening to this about reimbursement, pharmacy, what's happening from a distribution perspective. They've got some really good insights that they can talk to their provider about and also their pharmacist about.
Yeah,
so thank you very much from MedInsights Unleashed for your time.
Yeah, thank you, John and MedInsights Unleashed for the great conversation and empowering patients.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.